Hello everyone, welcome to the third part of management of COVID-19. We are checking the revised treatment guidelines from National Guidelines and Maharashtra State Task Force Guidelines from January 2022. I am Dr. Ashish. In today's video, we are going to discuss about factors which are associated with poor prognosis and higher mortality in COVID-19. We will review the same in clinical parameters, laboratory findings and radiological findings. In earlier video, we discussed that at-risk population with comorbidities have higher chance of severe COVID-19. As per State Task Force guidelines, in clinical signs, a 6% SpO2 drop after 6-minute walk test, SpO2 less than 90 and or respiratory rate more than 30 per minute, hypotension or altered sensorium, and rapidly increasing oxygen demand. These are some factors associated with poor outcome. Before going to other prognostic markers, the laboratory results should be timely, accurate and reproducible, and it should be interpreted with clinical picture of the patient. A blood glucose level and organ function test are also independent markers for severity, especially in Omicron wave, and should be monitored in moderate to severe COVID-19. Similar principles apply to X-ray and CT chest. It should be of good resolution and good quality, and again a clinician should see images personally instead of looking only at the severity scores, as the underlying other lung conditions like pulmonary edema or fibrosis can interfere. In laboratory findings, there is no specific marker with prognostic value, as many blood values are extrapolated from data of survivors and non-survivors of COVID patients that were admitted in hospitals. Prognostic values should be considered relevant in those admitted with moderate or severe disease in hospital, not in mild disease. In complete hemogram, a higher neutrophil to lymphocyte ratio and reduction of absolute lymphocyte count is associated with worse outcome. However, with steroids and secondary infections, the neutrophil to lymphocyte ratio also increases. That has to be kept in mind. Other findings like eosinophilia and thrombocytopenia are in some studies associated with poor outcome. Next, in inflammatory markers and biomarkers, the first is CRP. The C-reactive protein is a non-specific acute phase reactant with upper limit of 6 mg per deciliter. It is considered elevated if 5 times normal value. Hence, a baseline value at admission is necessary as it can elevate in other multiple conditions. A value more than 100 mg per deciliter is associated with high mortality. When there is a rapid rise of CRP above 50 to 75 mg per deciliter with hypoxic deterioration, it's seen in the cytokine storm, and it is the only marker which has therapeutic role in giving tocilizumab. The half-life of CRP is 24 hours. Hence, when clinical worsening, it should be repeated in 2 to 3 days. Next marker is LDH. It is present in all living cells and the value above normal is associated with poor outcomes. It is excluded from the national guidelines as non-specific elevation can occur in other inflammatory states, and also with sample collection techniques, hemolysis can occur and falsely elevate the LDH value. Next marker is D-dimer. Its value above 1000 nanogram per ml are seen in severe COVID-19, and the values about 3000 nanogram per ml were found in non-survivors with thrombosis associated with COVID-19. Next, in serum ferritin, the values above 500 microgram per liter were seen in severe COVID in cytokine storm. Again, being a non-specific acute phase reactant, if the baseline value available on admission and comparison during sudden worsening, then only of some value with other markers. Also, the half-life being long than CRP, it is excluded from national guidelines for monitoring purpose. Next, we have procalcitonin. Normal values are less than 0.1 nanogram per ml. The values up to 0.5 nanogram per ml are found in severe COVID, and values above these are also seen in secondary bacterial infections. Hence, the progressive increase in the procalcitonin with clinical deterioration is seen in worsening COVID, or it is associated with secondary bacterial infections. Next is interleukin-6 test. The IL6 test is costly and the false elevation does occur in sample collection technique or with secondary bacterial infection. A CRP test does give similar valuable information, hence we prefer to do CRP test. Radiological findings associated with severity. First of all, they should be interpreted with clinical picture and done as per the guidelines discussed in earlier video. In chest radiograph, findings appear late compared to CT chest, mean around 7 days. In those admitted with hypoxia, a baseline chest radiograph should present for comparison. With clinical worsening and appearance of ARDS, pneumothorax, pneumomediastinum or pulmonary edema or new infiltrates on X-ray indicates increase in severity. In CT chest findings, again should complement clinical picture as findings can appear in asymptomatic and normal saturation, and also in later phases radiological changes lag behind clinical recovery. CT findings are in various phases. Early in the first 4 days of illness, we don't do CT, but sometimes occasional GGOs are seen. Later, in day 5 to 8 is a progressive phase. We get multiple peripheral rounded GGOs or crazy paving appearance. In peak stage, in between 9 to 13 days, we get multiple areas of consolidation. In absorption phase, more than 14 days, parenchymal bands, honeycombing or bronchial dilatations, and persistent opacities in late phase, those stuck on oxygen. Pneumothorax, pneumomediastinum, pulmonary edema, new infiltrates, or extensive involvement of multiple lobes as given by CT severity score of more than 15/25 indicate worse prognosis. As per our experience, many patients having underlying chronic lung conditions, example COPD, diaphragmatic hernia, tuberculous fibrosis, obesity, pulmonary edema, that also influence severity in addition to CT severity score. The problem faced in our college was, in Delta wave, patients were getting admitted in very late stages of disease with higher severity scores and elevated markers. As treatment, patients were given steroids initially in response to hypoxia. However, rarely were the markers rising or obesity worsening. Most of the patient remained stuck for oxygen requirement. To summarize, comorbidities and falling SpO2 are considered as red flag signs for COVID worsening. Rising laboratory markers CRP, LDH, ferritin, D-dimer, procalcitonin with clinical worsening are associated with severe COVID and mortality. A clinico-radiological correlation of higher CT severity scores is associated with poor prognosis. In this Omicron wave, it has been observed that unvaccinated patients with comorbidities and underlying organ dysfunction are at higher risk to develop severe COVID and have higher mortality than fully vaccinated individuals. Thank you for watching the video.